So now is the meat of our meeting. We'll have 4 sessions, beginning with debates from some of our key stakeholders and members. I'd like to introduce the session 1 panelists. Dr. Senman, I believe, is leading the discussion as our moderator. Again, we want you to be provocative. This is about generating ideas, okay? It's not an echo chamber. We want to hear outside perspectives. We want to hear from the audience in particular, so we'll be roving with microphones. Thank you, everyone, for showing up, and hope you enjoy the rest of the meeting.
All right, good morning, everyone. If I can have the panel 1 panelists start getting seated, and I'll just do a quick intro about how the morning will be broken. So it is truly incredible to have this fantastic group together, especially as we tackle one of the most pressing and widely debated questions in our field, which is who is a critical care cardiologist and how does one become one? Given the growing interest and the debate around this topic, we really wanted to take advantage of the opportunity of being all in the same room with so many experts to explore this question in depth. That's why our morning session will center around the theme of defining and training the critical care cardiologist. These sessions are held in collaboration with the Association of Pulmonary and Critical Care Medicine program directors, recognizing that they play a crucial role in training us and making us who we are. So to kick things off, our session will be defining the critical care cardiologist, and we'll kick it off with a lively debate between Dr. Hansra and Dr. Berg, who will present opposing views on whether a critical care cardiologist is a distinct entity or if an intensivist is simply an intensivist, regardless of specialty. After that debate, we will open the floor to a broader discussion. As Dr. Katz mentioned, while our panelists will be guiding the conversation from the stage, we really want your engagement. We really want to hear your thoughts, and we want this to be a collaborative session. So don't be shy, come up to your microphones, and ask pressing questions, ask difficult questions that will make them sweat. So with that, I'll have our first debater, Dr. Berg, and I'll actually have each of the panel members just introduce themselves so it's a warmer environment we start with.
Hi, I'm Bindu Achanti. I'm a pulmonary critical care physician at UT Health, and I welcome you all to Houston on the 5 weekends that we actually have good weather.
My name is Ann Gage. I'm an interventional cardiologist and critical care cardiologist at Centennial Medical Center in Nashville, Tennessee.
I'm Ricky Hansra. I'm one of the critical care cardiologists at Vanderbilt.
Good morning. I'm Neil Chasen. I'm a pulmonary critical care intensivist, and I'm also representing as part of the Association of Pulmonary Critical Care Program Directors this morning. So thanks for inviting me. Incidentally, this is the most people that have ever watched me do anything. And so I'm going to invite Zoll to all my meetings as well. So, no, I'm just kidding.
My name is Jim Horowitz. I'm the director of the section of critical care cardiology at NYU.
I'm David Berg. I'm a critical care cardiologist at Brigham and Women's Hospital in Boston, Massachusetts.
Good morning, everyone. I'm Zach DeGiovanni. I'm an advanced heart failure cardiologist and critical care cardiologist at Centennial in Nashville.
All right, and we'll have Dr. Berg come up and defend his case.
Thank you, Belim. Thank you, Jason. Thank you, Marwan. It's really a privilege to be here for this inaugural SOC meeting. And I'm thrilled to be kicking off what's sure to be a great series of debates and discussion. And hopefully in the next 10 minutes, I'll convince you that yes, critical care cardiologists are distinct from other intensivists. So there are my disclosures. So in the critical care cardiology community, we've all heard the story about the origins of the CCU, which began when Dr. Desmond Julian, who was then a senior medical registrar at the Royal Infirmary in Edinburgh, was noticing that acute myocardial infarction patients were dying from sudden cardiac deaths. And he boldly asked the question, what if we cohort these patients together in specialized ICUs with nurses who are capable of performing independent defibrillation? Could we improve outcomes in MI? And of course, course, that set the stage for then decades of CCUs becoming the hubs of ACS care. But CCUs changed over time. The patients that were admitted to CCUs started to evolve. And so this was an analysis led by our fearless leader, Dr. Jason Katz, looking at admissions to the Duke University CCU between 1989 to 2006. And Dr. Katz found that there was an increasing proportion of elderly patients, of female patients, of non-white patients. Patients had higher Charlson comorbidity scores over time, and that reflected increasing burden not only of cardiovascular comorbidities, but non-cardiovascular comorbidities. And there was an increasing prevalence of non-cardiovascular acute diagnoses, including sepsis, AKI, acute respiratory failure, and pneumonia. Fast forward a couple years, and a group of people here, as well as outside of this room, came together to form a collaborative research network called the Critical Care Cardiology Trials Network, or C3TN Registry. And in this first paper out of C3TN, which included more than 3,000 consecutive medical CICU admissions from 16 CICUs across North America, one of the important findings was that the number one indication for admission to a CICU was respiratory failure. Respiratory failure, really highlighting the value of advanced training in mechanical ventilation and non-invasive ventilation to be able to adequately care for CICU patients. And so members and leaders in our community started doing their homework and tried to learn the lessons from critical care medicine more broadly. And one of those lessons related to physician staffing and outcomes. So this is a classic meta-analysis of 27 observational studies that compared outcomes in ICU patients admitted to units with high intensity versus low intensity staffing models. And high intensity, of course, referred to those units where there was a mandatory intensivist consultation or a closed ICU, where there was a single intensivist directing the care of all patients admitted to the CCU. And the key findings were that there was 39% lower ICU mortality and shorter ICU length of stay in patients who were admitted to units staffed with high intensity staffing models. And so the people who became the leaders of our field started coming together, and in 2012 issued a scientific statement on behalf of the American Heart Association about the evolution of critical care cardiology, calling not only for a transformation in the staffing models for CCU, but a change in how we train the next generation of clinicians who would care for critically ill cardiovascular patients. COCATS jumped into the mix and started envisioning what are the different training paradigms that we might use for training in critical care cardiology. And they envisioned a tiered system or a leveled system where you might achieve level 1 training if you were a cardiologist with basic training to become a competent cardiovascular consultant on ICU patients, all the way up to level 3 training. And the idea there was you take a trained cardiologist, layer on dedicated fellowship training in critical care medicine to have the complete skill set. And so over the last decade, there's been no shortage of additional calls for dedicated critical care medicine training for cardiovascular trainees who want to take care of patients in CICUs. This has been in the form of editorial statements, expert panels, scientific statements by a number of leaders in our community. And I'll point out, one of these was that came out of the Minnesota Critical Care Cardiology Education Summit that you heard mentioned. And on that document was my opponent as a co-author, Dr. Hansra. So agreeing with the notion that combining cardiovascular training and critical care medicine training was important. So I think many of us who have been practicing in critical care cardiology have gotten used to the discussion about what does the critical care cardiologist add that the general cardiologist may not have in terms of skill set. But now Dr. Hansra wants to flip the question around and say, hey, maybe it's just critical care medicine training that matters. We can just scrap the cardiovascular training altogether. And to that I would offer the analogy of building a house. So right now we've been talking about a model where we take trainees, we provide a strong foundation in cardiovascular medicine, we layer on, we scaffold on the advanced training in critical care medicine to form the complete critical care cardiologist. And so now, what happens if we just take away the cardiology piece? What could possibly go wrong with that model? So returning to that initial C3TN registry paper, and now not focusing on indications for CCU admissions, but underlying primary diagnosis, reasons that patients ended up in the CCU, I want to point out that the two most common reasons that patients are admitted to CCUs are still two things. And one is acute heart failure syndromes, which includes cardiogenic shock, the focus of this meeting. And then the other is acute coronary syndrome. So 19% of patients have acute heart failure, 32% have acute coronary syndromes. And I'm not a math major, but that adds up to about half. So about half of the patients that we care for fall into have one of these two acute cardiovascular syndromes. Now, Dr. Hanser is going to try to tell you that those lessons can be gleaned in a weekend CME course on top of critical care medicine training. But I would say that our professional societies argue otherwise. There's entire documents dedicated to each of these conditions, outlining the complex diagnosis and management of these conditions. And each of these documents includes more than 100 recommendations for the diagnostic and evaluation and management of these syndromes. Do we have any examples of subspecialty trained intensivists managing subspecialized critical care conditions and its relationship to outcomes? Yeah, we do actually. So this was an analysis of over 1,000 patients with non-traumatic intracranial hemorrhage, some of which were managed in neuro-ICUs, dedicated neuro-ICUs, and some of which were managed in dedicated or in general ICUs. And the investigators looked at what were the predictors of in-hospital mortality. Now, not surprisingly, older age, lower GCS were associated with increased survival, but there were two important signals with respect to staffing. So one of those was that having a full-time intensivist was associated with a lower odds of mortality, a win for critical care medicine for sure. But the other was that admission to a general ICU as compared to a neuro-ICU was associated with 3 times higher odds of risk-adjusted mortality, suggesting that admission to a neuro-ICU is associated with lower mortality in intracranial hemorrhage patients. Now, beyond the conditions that we care for, I'd argue that there's diagnostic and therapeutic technological expertise that the CICU-based clinician must have. And this is returning now to that statement that came out of the University of Minnesota Education Summit led by Andrea Elliott and Dave Dudzinski, in which we envision what are the technical expertise that a clinician might have to take care of patients in a level 1 cardiac ICU. And on that list is comfort and expertise in echocardiography, pulmonary artery catheterization, transvenous pacemakers, and temporary mechanical support devices, of which there's an ever-evolving armamentarium. So let's take SWANs as an example. These are data from the National Inpatient Sample that look at the use of SWANs in hospitals between 1993 and 2004. And over that decade, there was a 65% decline in the use of SWANs. And I'd argue that the SWAN has almost disappeared from the general ICU. Now, contrast that with cardiac ICUs. Again, these are data from the C3TN registry. This analysis included more than 13,000 patients. And 1 in 5 patients that we take care of in the unit has a SWAN. And if you look at the subset with cardiogenic shock, more than half have a SWAN. There was also this sort of intriguing signal that having a pulmonary artery catheter was associated with higher risk-adjusted survival in cardiac patients with shock. Of course, that signal needs to be validated in prospective trials. But I'm going to go out on a limb here and say that I don't think not having the exposure, not having the familiarity with the technology is going to be associated with better outcomes. And so really the expertise is concentrated in CICUs. What about temporary mechanical support devices? Again, data from C3TN tell us that 1 in 3 shock patients is managed with some type of temporary mechanical circulatory support device. And we know these are not set-it-and-forget-it devices. It requires careful attention with echocardiographic monitoring, invasive hemodynamic monitoring, understanding how these systems interact with other organ support systems like the vent, like renal replacement therapy, like neurologic monitoring. And of course, if there's been any lessons from the randomized trials of temporary mechanical support strategies, it's that complications are an issue and mitigating complications is critical. And I would say that part of the task of the critical care cardiologist is to have expertise to be able to minimize those complications. Now, don't take my biased word for it. This was a survey of trainees in general critical care medicine from a number of different specialties, pulmonary surgery, anesthesia, and critical care only, who reported their confidence with use of different cardiovascular technologies at the end of their fellowship. And you'll see that on the right, their comfort with non-cardiovascular procedures like bronchs, like intubation, mechanical ventilation was very, very high. Contrast that with their comfort with cardiovascular procedures and management of cardiovascular diagnosis, which was comparably much lower. Now, when I round with fellows in the CCU, I always emphasize that we're the quarterbacks of a well-run cardiovascular team, that we require close collaboration with interventional cardiologists, electrophysiologists, with heart failure docs, imaging cardiologists, vascular medicine docs, and of course, cardiac surgeons. We also spearhead multidisciplinary CICU-based teams, cardiogenic shock teams, PERT teams, acute aortic syndrome teams, and in many circumstances, CICU-based palliative care teams. And so I'm actually rounding in the CICU this week, and my fellow, who's from a different institution, commented to me yesterday. He's like, wow, that he was impressed by the deference and the trust that all of these different cardiovascular providers have in the critical care cardiology team. And I'd say that a lot of that is because we understand how the acute cardiovascular illness management relates to the broader cardiovascular illness trajectory and care. And so, bring that all together, I want to leave you with that training in cardiovascular disease is still the foundation of providing high-quality CICU care. And I want to remind you that acute coronary syndromes and acute heart failure syndrome still account for half of the patients that we take care of in CICUs. I'll also point out that CICU care requires highly specialized technological expertise not currently provided by general critical care medicine training programs, and leave you on the final note that critical care cardiologists really are the quarterbacks of cardiovascular teams. And so like this handsome guy, I am incredibly proud to be a critical care cardiologist.